And thank you very much for allowing me to participate in the Colombian Urologic meeting. It's my pleasure to discuss the Urolift system, which I have been fortunate enough to use now for about 6 years in my practice in the southern part of New Jersey. My practice was one of the sites involved with the initial trials, and we've had quite a bit of experience utilizing Urolift. I'll run through some slides, and hopefully this will pique your interest in the use of minimally invasive therapy for treating men with BPH. I think it really has changed our approach to BPH therapy here in the States. I think we've done a better job in managing our patients and offering them a variety of options to treat their symptoms. So let's talk about the indications and contraindications for the use of the Urolift system. It's certainly approved for treatment of symptoms due to outflow obstruction secondary to BPH, including lateral and median lobes in men 45 years of age or older. Now, clearly, the indications are appropriate, and I think that as you utilize the system more and more, you'll find a variety of techniques that make sense for you. We're surgeons as urologists, and certainly as you become more adept at utilizing a Urolift, you'll find different techniques that are appropriate for you and your patients. Obviously, there are some contraindications for patients, a volume of greater than 100 cc's, urinary tract infections, stricture disease, incontinence due to sphincteric issues, or current gross hematuria. I think the impetus for a lot of this has been the dissatisfaction men have had with BPH medication. I think we've all become a little bit lazy, and I include myself in the fact that when tamsulosin became available here, certainly in the US, we changed our approach to men and gave everybody medical therapy without really much follow-up other than a PSA, a rectal examination, and a post-void residual every 6 months or every year. We did nothing to really evaluate their lower urinary tract. And I think a lot of men, when given the options of continuing medication or stopping and considering a minimally invasive therapy, often choose the latter. Men don't like the side effects of the drugs, and many stop taking the medication without even telling us as their treating physicians. We know that alpha blockers can cause side effects including lightheadedness, headaches, fatigue, ejaculatory dysfunction, nasal congestion. We also know about some other issues, including an increased risk of stroke and dementia, and also obviously the floppy iris syndrome, which our ophthalmology colleagues have noted for many years. The other common drug that we often have used are the 5 ARIs, dutasteride and finasteride. And again, we know that those have issues as well, including diminished ejaculate, decreased libido, gynecomastia. And there's been some recent studies that there have been concerns about increased risk of dementia, metabolic syndromes, and depression. So I think when one looks at the options available for treating BPH, and although medical therapy has certainly been the mainstay for many years, I think with the advent of minimally invasive therapies, it really has changed my dialogue with patients and how I approach their treatment options. We also know that watchful waiting is not without potential complications. We've seen some of the long-term studies. Certainly the VA study looked at the 5-year outcomes of surgical resection and watchful waiting. And what we've learned is that for some men, delaying some type of intervention, in this case, an ablative procedure, can have significant deleterious effects on resolution of symptoms, including flow and post-void residuals. So I think what we've all come to the conclusion is that there's got to be a better way between just medical therapy or watchful waiting and a more invasive TURP. And I think we've all seen these cartoons, and I think I actually use some of this in my clinic to talk to patients about what the potential concerns are over the long term with outlet obstruction and what it can lead to. I think it's actually quite helpful. Patients really understand this. And we also know that patients who have outlet obstruction may develop irreversible bladder damage. We don't know the time course. It's never been a really good long-term study, but we certainly know this anecdotally. We've all seen this. And I think we all know that ablative surgery provides maximum disobstruction. But again, many men would prefer not to have to go that route. So I think that, again, we're looking for a way to manage these patients in a way that's effectively treating their obstruction, potentially without the invasiveness of an ablative procedure. So what's the Urolift? And again, I've been fortunate enough to have been involved with the device for some time now. And I've had a fair amount of comfort using it and trying to figure out which are the appropriate patients. I think what's nice about the procedure is it gives rapid relief with minimal side effects. Most side effects, which are typically irritative symptoms and occasionally some hematuria, resolve in a couple of weeks. No sexual function issues at all, and no need for a post-op catheter in the majority of patients. Typically do this in an office setting or in a outpatient ambulatory surgical center. Very straightforward procedure. And again, as surgeons, I think to learn the procedure is really simple with some basic principles. It's a durable procedure. There's been some good long-term looks at retreatment rates versus TURP. And again, it's minimally invasive. You're not going to get the same long-term effect as you would with a TURP. But again, you're offering these patients a much less invasive procedure. And reimbursement certainly in the US has been quite good. I'm sure that ultimately you'll see the same in Colombia. And again, this is the device. It's actually quite clever. It really is a disruptive technology. There's never been anything like this in the treatment of BPH. It's not like the typical heating procedures or microwave, all the things that we've used in the past. And it's a single-use device with a transprostatic implant, which is customized based on the size of the prostate and the use of known materials, nitinol for the capsular tab, stainless steel on the urethral side, and a monofilament suture. And again, if you can look at this cartoons, essentially it's compression of the prostate and then placement of this capsular tab, and then ultimately the urethral end plate to maintain the patency of the prostate, to change the caliber of the prostatic urethra and reduce the obstruction. And again, this is what you might see in a typical patient. And I think what we've also learned is, every patient's different, and visually not every patient looks the same. But if you follow the guidelines and the basic techniques, I think you'll find that these patients experience significant improvement in their urinary symptoms. So again, I think these are patients looking for reduction in symptomatology. Many are not happy with the side effects of medical therapy. In many countries, medical therapy is very expensive. Here in the US, it's often covered, but again, it can be expensive. And I think patients are looking for ways to avoid long-term medical therapy, again, for the reasons which we've already outlined. So I think this is really an option for many patients who are symptomatic, looking to be treated for their symptoms, but also looking to avoid long-term medical therapy and also avoid an invasive procedure. So this is what a typical pre-procedure cystoscopy would look like, with the typical lateral lobes. I think I was unable to get the video as I had hoped, but again, as you'll see, and I look to meet everyone in person so we can review some of these videos and discuss things in more detail. The other thing that's been, I think, quite helpful is the fact that there's been excellent clinical evidence. I give a lot of credit to NeoTract and Teleflex for really doing a good job in evaluating this procedure. There's been over 12,000 patients studied in peer-reviewed publications with some long-term data. Also some healthcare claims and utilization analysis. So I think, unlike many of the less invasive procedures that we've used in the past, these have been well studied with good data and reproducible data. And I think that's important when we had this discussion with our patients in the clinic about the use of minimally invasive therapy to treat BPH. The other part of the story, I think, is the fact that the AUA now has changed their guidelines and has changed what they feel is appropriate workup and treatment. And this workup includes cystoscopy and transrectal ultrasound, and again, the use of minimally invasive therapy. So I think that in the U.S., I think the train has left the station, if you will. I think that many of the U.S. urologists are beginning to adopt or have adopted this approach to treating men with BPH, and I think we're seeing the same around the world. And I hope that it's in the near future we can begin to discuss this in greater detail, discuss patient evaluation and workup, and ultimately how to utilize the Urolift procedure. I really like to thank Dr. Maurizio Plata for inviting me, and I look forward to getting down to Colombia in the near future. Have a good weekend, and thank you again.